The cut is barely an inch long. No shattered bone, no severed artery. Yet before antibiotics, this ordinary wound could become a death sentence. At first, you keep working. The pain is sharp but familiar. The danger is invisible, already carried on skin, cloth, soil, and steel. There is no pharmacy tablet waiting at home, no emergency department, no laboratory identifying the organism. Your body must win almost alone. Most small wounds did heal. Human beings survived cuts for thousands of years. But when infection took hold, medicine had few reliable ways to stop it. Your first decision is immediate. Wash the wound, cover it, ignore it, or trust a remedy passed down through generations. Every choice changes the odds. Clean water itself may be scarce. A village well can be muddy or contaminated by waste that nobody can see. Rinsing may remove dirt. It may also introduce more bacteria. Without germ theory, both outcomes look exactly the same. A strip of linen can protect the cut, but reused, poorly washed, or damp cloth may carry the next threat. Healers used wine, vinegar, honey, oils, herbs, resins, and cautery. Some methods helped. Others injured tissue or offered only hope. Honey can inhibit some microbes. Alcohol and vinegar may reduce contamination. But purity, dose, timing, and wound depth were uncontrolled. Cautery was harsher. Heated metal could seal bleeding or destroy damaged tissue, but it also burned healthy flesh and created new injury. The best advantage was often simple: a shallow, clean wound, good circulation, rest, nutrition, and luck. None could be guaranteed. By the second day, you inspect the edges. Mild redness may be normal. Expanding heat, swelling, and worsening pain are not. You do not know the name Staphylococcus or Streptococcus. The enemy has no name, and therefore no clear strategy. For centuries, illness was blamed on imbalance, corrupted air, bad humors, fate, or divine judgment. Treatment followed the explanation available. When the cause is misunderstood, the useful action can look pointless, and the dangerous action can look wise. In some periods, thick pus was called laudable, a reassuring sign that a wound followed an expected course. Not every draining wound was fatal, but pus also marks a battle among bacteria, immune cells, and damaged tissue. Your pain now pulses with your heartbeat. The bandage feels tight. Missing work, however, may mean losing food or wages. So you return. Sweat soaks the cloth. Dust settles into the fibers. Each hour gives infection more time and your body less strength. The wound may form an abscess, a sealed pocket where bacteria multiply. Without drainage, pressure and tissue damage can increase. A skilled healer may open and drain it. This ancient principle can save life, but the procedure is painful and the instruments may be dirty. Before dependable anesthesia, pain itself becomes part of the calculation. Endure the knife now, or wait and hope the swelling falls. Waiting can feel rational. Some infections resolve. Others travel through tissue faster than the eye can follow. Red streaks may climb from the wound. Fever arrives. Your pulse accelerates. The danger is no longer confined to the cut. Today, sepsis means a life-threatening response to infection that can damage organs. Then, it might simply look like sudden collapse. Confusion is one of the darkest signs. You may not recognize the room. The body is losing control of the battle. Chills shake you beneath blankets. Then fever burns. Thirst grows, urine falls, and every breath feels more expensive. There is no intravenous fluid, oxygen monitor, blood culture, or rapid antibiotic. Care may be limited to warmth, water, drainage, and watching. Survival depends on the organism, the wound, your health, and how quickly infected tissue can be removed or drained. If the infection remains local, your immune system may contain it. The swelling softens. The fever breaks. You survive the first test. But if tissue loses blood supply or bacteria invade deeply, tissue can die. Gangrene may result from infection, ischemia, or both. In crushed, dirty wounds, bacteria can thrive where oxygen is low. Gas gangrene can spread with terrifying speed. The pain may become far greater than the wound appears to justify. Swelling expands. Delay is now measured in hours. The surgeon's most reliable weapon is not medicine. It is removal, cutting away dead tissue before infection reaches farther. Debridement sacrifices damaged tissue to preserve what remains. In severe cases, the choice becomes even more extreme. Amputation can stop a spreading infection if performed early enough. Too late, and the infection may already be systemic. The operation brings new dangers: shock, bleeding, pain, contaminated tools, and infection in the surgical wound itself. Patients might receive alcohol, opium, ether, chloroform, or physical restraint, depending on the century and place. Speed became a surgical virtue. A fast operation reduced agony and blood loss, but speed could not make the room sterile. Surgeons once worked in everyday coats. Hands, instruments, sponges, and dressings moved between patients with little understanding of contamination. Hospitals could become reservoirs of infection. The place meant to save you might expose your wound to the illnesses of many others. Post-operative fever was so familiar that infection could be treated as an expected hazard, not an exceptional failure. Then the explanation began to change. Evidence accumulated that invisible living organisms could drive decay and disease. Ignaz Semmelweis showed that hand cleaning could sharply reduce deadly childbed fever, though his findings met resistance. Louis Pasteur strengthened germ theory. Joseph Lister applied those ideas to surgery, using carbolic acid to reduce wound infection. Lister's system was irritating, imperfect, and controversial, but it shifted surgery from accepting infection toward actively preventing it. Antisepsis did not cure infection already racing through the body. It reduced the chance that treatment would create one. Over time, aseptic technique went further: sterilized instruments, cleaner gowns, gloves, masks, and controlled operating spaces. Clean surgery, drainage, debridement, sanitation, and nursing improved survival before antibiotics arrived. Deep infections still held the final advantage. The first major antibacterial revolution did not begin with penicillin. Sulfonamide drugs entered clinical use in the 1930s. Penicillin then moved from laboratory discovery to mass production during the Second World War, transforming treatment of susceptible bacterial infections. It was not magic for every organism, and early supplies were limited, but medicine could finally attack bacteria inside the body. The balance changed. A wound that once demanded drainage, amputation, or prayer might now respond to a course of medicine. Antibiotics never replaced wound cleaning, drainage, surgery, tetanus prevention, or supportive care. Dead tissue still had to be removed. That old danger still matters. When bacteria resist treatment, infections become harder, slower, and sometimes impossible to cure. The lesson is not that every scratch is terrifying. It is that skin protects an enormous internal world from invisible invasion. Before antibiotics, survival meant preventing contamination, recognizing fever early, draining infection, and accepting brutal surgery when delay meant death. One small cut could steal weeks of work, a hand, a leg, or a life. That was the brutal arithmetic of infection. One small cut, one invisible enemy, one decision made too late. Before antibiotics, could you survive this?